करिए सर।
डॉक्टर राजीव देंगे ना वेलकम एड्रेस?
हाँ हाँ, तो हमको बोलना है ना, स्टार्ट करिए ना। प्रिंट बता जल्दी से दो, प्रिंट आउट, या दो तो मोबाइल पे दे दो सर। बस 2 मिनट रुकिए सर, 2 मिनट रुकिए, 2 मिनट पहले
लाइव मैम।
So good morning all. So we are you all are welcome to the second module of glaucoma PG teaching webinar. And today our speakers are Dr. Anindya Anuradha. She will be talking on visual field analysis. Our second speaker is Dr. Abhishek Onkar. He will be talking on RNFL analysis. And our guest speaker today is Dr. Sunita Dubey. She will be talking on pediatric glaucoma and tube implants. I invite Professor Rajiv Gupta, HOD RIMS Ranchi, the biggest teaching institution, for the welcome address. Yes, sir.
Hello, good morning.
Yes.
Good morning to everyone. Glaucoma is going to be held. I welcome all the speakers. Will share their view to all the postgraduate students. Hope all the postgraduate students will get benefit from this webinar. This is a very good initiative by CAS in association with AIOS. So today you now be prepared for the talk and get benefited from this webinar. Again, I welcome all the speakers, participants, Dr. Bhartika sir, Dr. Anuradha, Dr. Abhishek, and the others. Thank you. And now to Bhartika sir to conduct the webinar.
Thank you, sir.
Thank you, sir. Thank you, sir. And I request all the PGs, at least please unmute yourself, and please, every time I tell, but the head of the institution's responsibility is to request their PGs to unmute and to keep the video camera on. In my hospital, everybody is sitting at one place and they are attending. Last time also I took a picture of everyone and shared. But I request the CCL PGs. Yesterday also I talked to Dr. Utpala. Please be Bokaro PGs and this CCL PGs. Please keep the video on. And this one PG I am seeing, she is from CCL. Dr. Richa. Dr. Ankur is CCL. Dr. Smita Anand is a faculty. Okay, so 2 PG का केवल कैमरा ऑन हुआ है, बाकी सबका ऑफ है. तो Dr. Utpala, the head of the institution, please tell them to keep the video.
I already told them. I told them yesterday.
हाँ, तो इन लोगों को पनिशमेंट दो. 3 आदमी आया, डॉक्टर सनवली, हम लोगों का पीजी का भी कैमरा ऑन कर दो ना, कम से कम सना दिखे.
मैंने सबको बोला, रोज बोला, बहुत बार बोला. If they don't,
I am also present, ma'am. Dr. Shankar.
डॉक्टर शंकर is there. तो 4 पीजी एटलीस्ट. उत्पला का कल सिग्नेचर भी सब आया है और उत्पला के ही पीजीज का वीडियो भी ऑन है. रीचा है, अंकुर है, शंकर है, ये सनवली है, और ऊपर से सना और समीर को वीडियो ऑन कराओ.
निराला क्यों नहीं ऑन करता है?
हाँ, बोलो सबको वीडियो ऑन करने के लिए. हम लोग संडे के दिन में आ जाते हैं. हाँ, आ गया है. कश्यप का पीजी सब भी है. आई कैन सी. अनम्यूट करो समीर. समीर एंड सना.
Shankar, tell KP Nirala.
Okay.
So I can see the PGs of Kashyap Memorial Eye Hospital also. Sana and Sameer, they are there. And और सबको वीडियो कैमरा ऑन कराओ. This is Dr. Tanisha, very nice, and Dr. Ashish को फोन करो. और because we need the Sunita Dubey wants discussants. Aninda will be going, so Tanisha should be there. Ashish Shyam should be there, because if the discussants are not there, the guest faculty feels bad. So everyone, when the guest faculty comes, Rashi, please join. नहीं लिंक, फैकल्टी लिंक भेजो उसको. फैकल्टी लिंक भेजो उसको. जल्दी भेजे पर्सन. हाँ तो I request everyone, now we are going to start, and I request everyone, I request Anindya also, because she does those surgeries, that they should honor the guest speakers, and when the guest speaker comes, they should come as discussants. So now over to Dr. S.K. Mitra for introduction of speakers. Yeah, speaker introduction.
Good morning. Good morning, everyone. It is my privilege to welcome you all in this. Am I audible?
Yes, yes, sir. You are very much audible.
It's my privilege to welcome you all in this Sunday lovely morning to this JHOS Glaucoma PG training webinar at Jharkhand Ophthalmic Society initiative, supported by head of the institution. Before welcoming, I just introduce our speakers and guest speakers. The guest speaker is Dr. Sunita Dubey of Soft Charity Eye Hospital, New Delhi, Dr. Abhishek Onkar of AIMS Devghar, and the Aninda Anuradha of Ranchi will be our internal speaker. So I introduce Dr. Sunita Dubey. She has done a fellowship in glaucoma at Wills Eye Hospital, Philadelphia in 2002, extensive experience in training fellows and residents in glaucoma for the past 2 decades, more than 100 publications and book chapters in various prestigious.
Dr. Mita,
Yeah.
Mita, don't do her introduction. When she comes, then we will do. First, do introduction of these two JHOS speakers.
Okay.
We are Anindya Anuradha's introduction.
Okay. Okay. So I just introduced Dr. Aninda Anuradha. She is the Glaucoma Fellowship of University of Toronto, Canada, HOD ophthalmologist, Bhagwan Mahavir Medical Super Specialty Hospital, Ranchi, Jharkhand, and is the course instructor and founder at Advait Eye India Foundations, mentor at the Center of Ophthalmic Research and Training, special interest in pediatric glaucoma, awarded by then Honorable Governor Mrs. Draupadi Murmu for in contributions to health, and 5 years prospective study on AGV tube movement published in Glaucoma Journal, and she has participated as a faculty in GSI PG teaching programs. I also introduce, should I introduce Dr. Abhishek now or when he speaks? I also introduce Dr. Abhishek Onkar, Department of Ophthalmology, AIMS Devghar. He is the master in MS Ophthalmology. He has done from Sarojini Naidu Medical College, SNMC Agra. He is a senior resident of All India Institute of Medical Science, AIMS Jodhpur, an assistant professor, Andaman Nicobar Islands Institute of Medical Sciences, associate professor of and head of the department, All India Institute of Medical Science. Please project that. Please project Dr. Anuradha's, Dr. Abhishek's screen.
Good morning, sir. Good morning, madam. Should I start my presentation now?
Yes.
Yeah, okay, thank you. I'm sharing my screen, and thank you very much, JHOS, Dr. Bharti Kashyap madam, for giving this opportunity. So today my presentation is on Humphrey visual field analyzer, and I will request all the postgraduates to participate to their best, and they can ask questions if they have any doubts. I'll go fast. However, every slide or every 2-3 slides, you will get questions. So please be ready. And the questions will be very simple, very easy. So this is something that all the postgraduates should be able to answer. Okay, if you will not answer, I will take your name. Okay, so this is the first slide. Let's go there. You are seeing a picture there, right? So what is this picture known as? Dr. Shankar, what is this picture? Dr. Shankar, are you there? Any of the PG? Can you identify what is the picture? No. Okay, so it's actually explained
Visual
by
field.
Yeah, it's I have already shown. It's actually 3D representation of visual field, where it's a very significant sentence that is mentioned for this picture. It's an island of vision in the sea of darkness. So this base we consider it's a sea of darkness, that the area that we are not seeing at all. And this is the it's a shape is like a hill, so that is why it's known as island of vision. And this 3D dimensional picture has to be presented in a 2D report, which should be very much repetitive, very much useful to understand for all this doctors. So that is why the visual field analyzer came into the picture. And it's a very important diagnostics tool, not only for glaucoma and also for the neurological diseases. So the thing is that it's a subjective type of test. So hence you are very much dependent on how the patient is performing the test. So what are the things you need to differentiate, whether the disease is actually present or not, or the defect is due to some other disease, or there is some artifacts due to some abnormalities. So good interpretation skills are required to identify several key plots, graphs, and indices. So these are the three things that we usually look forward in a visual field. One thing is we have to diagnose the ocular disease depending on the pattern of the visual field defect. The second thing comes whether to decide whether there is any progression or not. This can only happen if you have multiple visual fields. That's a series of visual fields over a period of time to identify whether there is progression or not, to compare with the baseline. Then comes the rate of progression. If there is any progression available, then in that case, what is the rate? So as per that, the treatment will depend on. So as we understand, when suppose you are going for your personal clinical practice after your post-graduation is complete, and you have to choose between OCT and visual field for glaucoma assessment, and if finances is a constraint, definitely visual field comes as the first choice. So visual field reports are divided into 8 zones. We'll be going through one after another. And let's come to the zone 1. That's the demographic data or the test, and also the test parameters. So in the demographic data, you have to match that yes, you are doing the correct patient, correct age. Suppose your age introduction is different, is wrong. So in that case, because in visual field, everything is correlated as per the age. So the outcome will be, it will be faulty. The same thing also pupil size, because if the pupil size, it's actually there is a automatic entry into the pupil size. The machine has that thing. You have to make sure it is switched on, because if the patient's suppose pupil is very small due to pilocarpine, definitely there will be rim defect. So all these things you have to look forward. Okay, so let's come to the second zone, that is the reliability indices. For example, one point is fixation loss. So actually the stimuli are actually it's given on the blind spot, because the blind spot is actually the optic nerve. So where the patient should not be able to see. If the patient is able to see, that means there is a fixation loss. Patient is moving the eye, so you must stop and redo. These are the following points how to identify the fixation loss. One is blind spot stimuli, we have already talked about. The other thing is a gauge tracking, that you will see in the down part of the print. The other thing also, through the video tracker, you can also see the patient is moving or not. In the same indices, reliability indices, you will get false negative. That means actually the patient is seeing, but the patient is not pressing the trigger. So that's the false negative thing that we have noticed. And also false positive is present. If suppose there are points where patient should not see, but the patient is pressing it over, and the interpretation will be false positive. Now you will be going to the question. Okay, so this is Dr. Samir, Dr. Other Shankar who are present there. Please see the visual field and please mention what kind of reliability indices is gone. Fast, be quick. What kind of reliability indices is affected in this case? No response. Okay, so now you see here. This is the answer. This is a clover leaf, right? So just like this shape, this indentation, you will get here. This is the indentation, right? So this is a false, that means it's a false negative. So false negative is associated with a clover leaf pattern. This pattern you will get in the visual field. So here you see false negative is 20%. So that is why you have got this shape, right? So now coming to this, this is a visual field of one patient in first visual field. Then this comes the second visual field. So of the same right eye, right? The same patient. So what is your interpretation in this case? Anybody can answer. Okay. So you will see that in the first visual field, there are, few points where you are seeing in the down of the, the lower side of the visual field, you will see there are a few points where there is depression. But here there is no such points. We'll see it is completely, the lower quadrant is completely normal. Every point is fine. And you will see it is on the same date the visual field is done, right? Both. So it's not that the patient had actually a defect and now the patient is improving. It's not like that. It's actually a learning curve. So hence, whenever there is a doubt that the patient is progressing, you must do visual field twice. And especially for the first baseline, you must do it twice to confirm that you have received a reliable visual field. Okay, so then this comes as the grayscale is the zone 3. So zone 3, this grayscale is specially utilized to explain the patient stage of disease and its progression over time, because it's very difficult to explain the patient all these normative data and this thing. So, but grayscale is something patient can understand. And most importantly, the grayscale is also utilized to identify whether we have a neurological defect. Because in the neurological defect, the pattern will be different than the glaucomatous defect. Okay, so next comes your zone 4, that is the total deviation. So total deviation, what happens that there is here is the retinal sensitivity. So normally retinal sensitivity is like 34 decibels. And then, it changes from point to point. So in total deviation, what happens, that is the difference between the normative data. Suppose a point is 32 here. Normally, it should have been 33 in a normal patient of that age group. But for this patient, it is 32. So that the both difference will be taken and here you will get the number -1. That is how all the points you get here, -2, -1, sometimes +1, 0. So 0 means, suppose here you will get a 0. So here it is mentioned, it's the 33, right? So 33, so in a normal patient also 33 is there for this age. So that is why you are getting 0. So that is how you get the total deviation. So now let's come to the pattern deviation zone 5. So as you know, pattern deviation is utilized to remove the diffuse cause of decrease in visual field. It's just like cataract. So the machine finds out what is the, like, suppose here you will see it's mentioned 0 here. However, if you go here, this will be -1. So this difference is happening automatically by the machine. So here you will see it's a -1, but here in this case it is happening -2. So this automatic reduction happens in the machine to find out the localized defect. Well, so what is wrong in this case? In this visual field, anything, see, the total deviation you were seeing, it's quite good enough, but in the pattern deviation, it is very bad. Do you think it is normal? Pattern deviation should be always better than total deviation. But in this case, you will see the pattern deviation is grossly affected. Why so? Because you will see also here the gray scale is almost there a defect so many places. So this is happening because of a very excessive high false positive. So in excessive high false positive cases, you will get pattern deviation extremely bad in comparison to total deviation. Okay, so zone 6 is the global indices, and the VFI is actually, that's the representative of a single number of the visual field. So suppose here it is mentioned 100% VFI. That means the patient is able to see 100%. It's a very good tool to show to the patient, yes, you are seeing 90%, 92%, like that. So it's a overall assessment of the field, visual field. So what are the other indices that you see in this segment? It's also mean deviation. So mean deviation also helps in the grading of the visual field. So mean deviation, if it is better than -3, that means it could be no glaucoma at all. And -3 to -6 is considered as a early defect, and -6 to -12 as moderate, and anything more than -12 MD is considered as a severe visual field defect. In terms of severity of glaucoma, this is how we classify the visual field, right? So pattern standard deviation, you get it, degree to which the shape of the visual field differs from the reference field. Then next comes the GHT, what is known as glaucoma hemifield test. So this test is done by comparing the superior and inferior visual field. So the mirror image analysis, we have to compare that whether these points are equal to this lower points or not. If there is any difference, you will get the GHT in this thing. Like whether if they're same, then you will get within the normal limit, or in the doubtful case borderline. The other cases you will see outside normal limits or abnormally high sensitivity or general reduction of sensitivity. These are the 5 kind of GHT that is possible in a Humphrey visual field. Well, let's come to this zone 8. That's actually the numeric presentation. So this is the absolute number of the retinal sensitivity. So this is measured by decibels. The range is from 0 to 50 decibel. So more than 30 decibel at any point is fairly normal, and 0 to 20 decibel indicates low sensitivity or significant visual field loss. And if anything, you will will see the patient has more than 40. As I said, it's usually the center field is 34, 33, like that, the foveal points. But if it is more than 40, that means it's a hypersensitivity. So what you are getting is false positive, that is trigger happy. So it's an unreliable test. From here, you can also identify. Okay. So obviously the center is more sensitive, and the periphery you will get lesser value. And it is not at all defective. You don't think that there is, if something, here you will get 26, 28. That does not mean it's actually defective from this number only, because as going to the periphery, obviously the retinal sensitivity will be reduced. Well, so what are the strategies we have to select while doing the test? Either you can choose 30-2 or 24-2 in glaucoma also. However, 24-2 is more preferred, depending as the points within the 24-2 are more sensitive for glaucoma. 30-2 is more preferred for neurological visual field defects. Then you will come to see there is something in the stimulus size that we have already mentioned in the first zone, right? So commonly we consider stimulus size of 3. However, stimulus size of 5 is also taken, especially when the sensitivity is reduced. Then comes whether to consider 24-2 or 10-2. So 10-2 you will be taking in patients in whom central visual field is already affected in 24-2. Then CETA standard versus CETA fast. CETA standard is normally used for all the patients to detect the disease or detect the progression. However, CETA fast is a strategy that is used for screening test because it will be more faster. So whenever we'll be analyzing visual field, must see for the both eye. Only seeing one eye will not come to a conclusion properly. So when looking at the visual field, you should also correlate with the other eye diseases. Suppose here we are seeing the visual field is very grossly affected. You will find, okay, it's a very severe glaucoma defect. However, if you will compare, you will see the nerve, see the optic macula, you will find there are other retinal diseases also. So it doesn't mean you will be diagnosing diseases only from visual field. Your visual field must be correlated with your fundus finding. Like here, this kind of visual field defect is not possible with this kind of optic nerve. So there is maybe some defect. It could have happened that there is a change of the reports between the patients. So enlargement of the blind spot, this is the blind spot. This enlargement can happen with the disc edema, myopic fundus, and optic disc drusense. So scotomas are divided into two types. Scotomas are actually laser depressed part of the visual field. So either it can be absolute scotoma or relative scotoma. Absolute scotoma, you will consider this when even after increasing the stimulus, the defect will be there. It will not go. It will not change. That is absolute scotoma. That means there is complete absence of sensitivity. Relative scotoma is there when if you increase the stimulus size or stimulus intensity, the person will be able to identify the stimulus. So this is relative scotoma. So then glaucoma versus neurological field defects. See, in glaucoma, it will follow the horizontal meridian, right? But in case of neurological defects, it will follow the vertical meridian. That is how you differentiate. Okay. So in this patient, what are you going to do next? Anyone please answer. This is a visual field. What are you going to do next? See, here is the central field is affected. As we have already discussed, once the central field is affected, so you will go for 10-2. So you'll find in the 10-2, there is a defect. We should follow up with 10-2. So thank you very much. Hopefully I have finished on time. I'm stopping my share.
Very nice. You can take some more time. Very
Okay.
nice.
Any questions from post-register?
I welcome Dr. BP Kashyap also, the head of the.
Hi, Anindya. What
Hello,
a
sir.
marvelous.
Good
Anindya
morning,
taught
sir.
very well.
Good
And
morning.
really-
What a marvelous talk, Anindya. Whenever I hear you, I learn a lot of things like today. Very nicely explained, and basic things you have explained very nicely. So I
Thank
think
you, sir. It's your greatness.
I think everybody, all the PG should have been listening to you, and then they must have learned a lot of things. Anindya, tell me one thing. If the patient has got I was delayed. I don't know whether you have covered it or not. So
Yes,
suppose
sir.
if the patient has got a high refractive error and you have to put on the glasses, what difference does it make?
Yeah, spatially for the first zone 1 I have mentioned in the slide only. So there the students must have find out that there is a column where you have to put the refraction status of the patient, because in the visual field the patient is within the dome. So the patient has to see the near vision. The near vision has to be absolutely fine. So the near correction should be there along with your distant correction. So otherwise there will be an unnecessary defect in the visual fields. There will be a reduction of sensitivity in all the parts because of the refractive power abnormality.
So roughly, if the patient is more than 50 years of age, you're going to add +2 or 2.5?
Yes, sir. Yes, sir. Absolutely. as per the age, we have to add because the near distance has to be taken care.
So if the patient has distance power and near power both, so how you will put so many glasses? The spectacle is, you will ask the patient to wear the spectacle?
Obviously, we have to go for the effective power for the near. So whatever is the distance power, we have to add with the near power.
Okay.
The effective power, whatever we will get, we have to add that power so that we
Okay.
can get rid of, putting so many, glasses in the.
So effective power for the near, you have to put before.
We have to put very, madam has asked really a very important question that, PG should have asked. It's a
Yes.
very nice, message to all the postgraduates. She has raised a very significant point here.
Because
Actually, Dr. Bharti,
Huh.
ma'am, in Humphrey, when we are entering the patient data, we have to enter the power also. And it generates a spherical equivalent. And then you have these power lenses that you have to mount onto the machine. And that lens
Yes.
comes in front of the patient's eye. So it is
Yes.
a spherical equivalent of distance and near.
Yes.
That is what helps the patient to see clearly.
नजदीक का जो effective power है means you are saying a spherical equivalent of distance and near, and she is saying just suppose.
So suppose there is a high myo patient with -7 and maybe plus 50 years, so 2.5 also he is using. So when we enter patient data, actually refraction has to be done before doing a visual field. So
what I am saying, suppose patient को -7 का power है, okay? Please सुनो, ये बहुत practical point है. 7 का power है, 2.5 near में लगा रहा है, right? वो लगा रहा है, 2 लगा रहा है, तो उसको 5 का effective near vision करके टेस्ट करना होगा ना.
We don't have to calculate ourselves. The machine calculates and tells us because उसमें cylindrical power भी हुआ ना. Suppose
yes, ma'am. You both are actually correct.
Yeah.
With the upgradation of the machines, it is already there that the machine itself will calculate and will guide us what the power we are going to put.
Exactly.
So as per that.
भर देना है. Humphrey ने सारा patient का डाटा भरने पर वो spherical equivalent देता है.
It tells you a power, yes. And then there is this mount on which a trial set comes with all the powers. So what power lens you have to put on that mount, the machine will tell you. That lens is fitted onto the mount, and then when the patient puts the chin on the machine, the lens comes in front of the eye, and through that the patient sees and does the field.
अरे वो तो सही है, लेकिन ये
वो power machine generate करता है.
ये machine.
Yeah, ma'am, you are also saying correct, ma'am. Bharti, ma'am, you are also saying, there are models in special, government medical colleges where, the process that you are saying that has to be followed. So Rashi, ma'am, is also saying absolutely, fine.
You said you said effective near power calculate करो. Rashi is saying कि spherical equivalent को उसको calculate करके देना है. Dr. Sunita Dubey is here. I want to listen to her. कि कैसे करते हैं?
Yeah, I think Dr. Rashi is absolutely right. She's absolutely right. In Humphrey machine, you don't have to calculate yourself. Machine does it for you, and basically it is a near. So
yes,
because the patient is performing the test at 33 centimeters, so it's a near this thing.
So machine is calculating for near, right?
Yes. Machine is calculating if there's cylindrical power also. It comes.
Yes. Of course.
Lenses, and those lenses are rimless lenses. So you cannot wear your glasses and perform the test because glasses will have rim and it can have rim scotoma. So your rimless glasses are the holder. Okay, so I think it is absolutely necessary to have the refraction done before you perform Humphrey visual field or any visual field testing. Refraction is very important.
So the message is, so the machine calculates itself the near power, which incorporates the cylinder also.
Yeah.
Okay. I really appreciate Dr. Sunita Dubey.
Can it be easier to have tell the patients to wear the spectacles before the test, during the test?
No, they don't wear spectacles. There is the lens. So you just have to put those glasses, rimless rimless lenses have to be put. Patient doesn't wear glasses and perform the test.
Because that should be rimless, yes.
Yeah.
Yeah.
So
And
ये
Dr.
rimless-
Mitra, actually, we get referrals for only field. For patient has come only for field test. So I would like to convey that if the refraction is done from before, it becomes very easy. The patient comes, the field is done, we report and send the patient back.
तो ये rimless glasses
Otherwise-
कहाँ मिलता है?
It comes in the trial set of
Trial
the
set.
machine. There is a separate trial set which comes off the machine. It has a wire rim, a round lens mounted on it with a small holder. So
नहीं,
it
हम
does
लोगों
not
की machine
encroach
में है
on
कि
the
नहीं?
field.
I doubt हमारे machine में है कि नहीं?
नहीं,
रहता है, सब
we
में
have
नहीं
that
हाँ, all
trial
the
set.
machines में होते हैं।
होता होगा
This-
जरूर।
आपका
Yeah.
आपका होगा ही।
अरे बेटा हम लोग ग्लोकोमा फील्ड में नहीं है ना, तो I am not aware.
So you don't know, but there is a special kind of trial set in which the rim is not there. वो जो पतला चौड़ा ऐसा रहता है normal उसमें
हाँ.
trial set वैसा नहीं होता. It is just a very small rim all around, which just it holds the glass. That's it, and a very small little bit of holder. So it does not give you the ring effect on the visual field.
And Dr. Anuradha, one more question, a very practical questions. How to distinguish between the generalized depression due to the cataract and the normal visual field defect?
अरे वो तो पैटर्न डेविएशन से हो जाएगा ना, वो जो टोटल डेविएशन को पैटर्न डेविएशन मिला घटाने से दिखता है.
Yes, that PG should understand that there is how to.
PG has to understand.
Yeah, absolutely. What ma'am absolutely said, it is something that PG should understand. That this is the use of pattern deviation, that to differentiate it, whether it is due to glaucoma or it is due to cataract.
Yes.
2 points, ma'am. Like already sir and ma'am already emphasized the point regarding the rim artifact. So we have to use those rimless. So that was the first point that already has been taken care of. One more question, like for the PG's sake, actually, usually we perform on Humphreys, all the fields, but at some places you also have the octopus. So there's the interpretations become a bit hard if they're not used to it, like especially the baby curve that you get. Like visual field indices go good for the Humphreys when you are analyzing the progression. But can you just, or ma'am can comment about the baby's curve and how to interpret it for the postgraduates mainly, ma'am?
If you're using an octopus, there's a baby curve and that is very, very useful. So if there is a diffuse opacity like a cataract or corneal opacity, the baby curve, they give you a normal baby curve. And this baby curve, there's an opacity, the depression of those illuminations are, it is almost parallel. It will be down, but then parallel to the baby curve, almost parallel to the baby curve. But if it is because of the defect of the visual field, the defect is almost, it comes down steeply and goes down steeply. So it is not parallel to the normal baby curve. That's the great difference. And this is very, very helpful.
Thank you, sir. Thank you, sir.
So if there is no more questions, we should move ahead to the next speaker, Dr. Abhishek Onkar. I just have the privilege to introduce Dr. Abhishek Onkar. He is the Associate Professor and Head of the Department of Ophthalmology, AIMS, Devghar. He has done MS Ophthalmology from Sarojini Naidu Medical College, Agra in 2013. Senior Residency, All India Institute of Medical Science, Jodhpur, India, 14 to 17. And he done assistant professor was Andaman Nicobar Island Institute of Medical Sciences, assistant professor and head of the department, All India Institute of Medical Sciences, Devghar, since 2021. And he is the reviewer of Indian Journal of Ophthalmology, Indian Journal of Cancer, BMJ, and associate editor of Open Access Journal of Ophthalmology. He has got 25 publications and 40 plus presentations. Awarded AIOS PNCNA Fellowship Award in 2014, APSO PRS Hong Kong Travel Grant, and WOC 2020 Travel Grant. He has done short-term fellowship and training in phaco, glaucoma keratoplasty from the Venuvai Institute of Medical Institute, New Delhi, and Sarvodaya Eye Hospital and Cornea Clinic, Mumbai. He's a consultant of Aster Eye Care Institute of New Delhi from 13 to 14 and associate consultant Center of Sight Jodhpur 2017 to December 2017. So I welcome Dr. Abhishek Onkar. You have to just go on for your presentations.
Thank you, sir. Thank you for the kind introduction. Good morning to all the seniors, respected seniors, and I thank JOS Scientific Committee and especially ma'am, Bharti ma'am, for giving me this opportunity and keeping me on the edge for this presentation. So without further ado, I will just start sharing my screen. I hope my presentation is visible.
Yeah, it's very much visible. Go to the full screen, please.
Right. So the talk that has been given to me is regarding the retinal nerve fiber layer analysis. My talk becomes very easy because of the previous Sunday's talks and especially the preceding talk regarding the visual field. So I will just go through what Rudyard Kipling said. Whenever we have to learn something, we have to keep these 6 friends in hand. And if we can explain these 6 things, we can actually answer everything about it. So we'll just try to elucidate it through a few examples. So first of all, the basic things, because this being a PG, mainly for the PG purpose, the basic things we already know what retinal nerve fiber layer is. So it's basically the ganglion cells that extend the axons of the ganglion cells, but it also has in addition the contribution from molar cells and the neurological cells. Now, the appearance we already know, and this explains a lot to why we get those arcuate defects and why the field defects occur first in the arcuate fashion and leading to that hemifield effects, because usually you get that fovea lies beneath the optic disc, so the discrepancy in the hemifield test. That was part and why the damages occur more near rather than for the peripheral vision. This is central to understanding the retinal nerve fiber layer analysis also. We cannot separate RNFL from the fields. They go hand in hand. When a postgraduate looks through his direct ophthalmoscope or a 90D, 78D, this is one thing that they should be looking at. This is an art which has gone missing, I used to say, of late. Just as if you ask a medicine graduate whether they know how to palpate a spleen or liver or kidney nowadays, rather than they go for ultrasonography, nowadays we are just missing this art. We just go for OCT basically after the perimetry part. But this is something which is very visible and which can be picked up. But this is difficult, obviously. This was, first of all, elucidated by Quigley and Hoyt and Vogt initially. And they actually did mention it, that these arcuate defects are difficult to pick up and especially difficult for general ophthalmologists to learn. But still, this is something you can get even if OCT misses it in the early stages. And the RNFL defect actually looks like and it follows the RNFL pattern. So you get those RNFL defects. At this point of time, just stop for this question for if any PGs, if they can interact, because this is supposed to be an interactive session and not a didactic or a Socratic one. So you can see a glaucomatous disc with cupping, nasalization of vessels, and this arcuate defect in the inferior part. So can anyone just comment like where are you going to find the field defect to perform a perimetry? Just 5 seconds if any PG can just go for it, or we will just move to the next slide because of paucity of time. Even please. Okay, so this is like a very common icebreaker, a very simple question because the fields reflect just the opposite to what you see in the fundus. So you are going, since the RNFL defect is in the inferior part, you get a superior field defect. And this is one thing that you need to corroborate. Whenever you are doing a OCT, always corroborate it with your perimetry findings. So normal values, I won't go into the numbers, but it's roughly like 110 to 105 differs in Caucasians and Asians. For in an Indian study, it mentioned about 104 microns and always the superior. Now, this is something in contradiction to what we get from the global reports. Usually the inferior part is the thickest, but they reported it to be the superior RNFL to be the thickest, maybe taking into account the temporal part as well. Now, why should we be evaluating RNFL? As I said, this has been a neglected part as far as fundoscopy is concerned when you perform for glaucoma evaluation. So the definition itself says it's a optic neuropathy. And what is optic nerve? It's basically a axons of the ganglion cells. So if the defect is in those cells, that is what you have to evaluate. And the loss of retinal ganglion cells is the pathology. So that becomes very pertinent, and why the why part is explained by this only. And an alternative to visual inspection is the analysis part when we go to the OCT, and that also gives a quantitative estimation of the cell loss. And if you are able to pick up those defects, it helps you not only in diagnosing pre-perimetric glaucoma, but also in different, like in last Sunday's class, there was a query regarding if there is a glaucomatous cupping or a physiological cupping compared to a glaucomatous, how to differentiate. So it is difficult, definitely it is difficult, but yes, if you do a proper RNFL analysis and OCT, you may pick up because of some very subtle observations that we will come to later on. Now, the RNFL defect loss has been found to be almost twice in those patients developing a visual field defect later on. This has already been mentioned by Hood et al. Now, the greatest amount of thinning that follows the ISNT rule, inferior part is usually the affected most. Now, this is the part that I was mentioning, like glaucoma suspects who you have to differentiate from myopic or physiological cupping. So they do not obey the ISNT rule when you do the RNFL analysis. So in those, the area under the curve for the median and the lateral part are like more disturbing rather than the vertical part, which is very typical for glaucoma. Now, coming to how part of the analysis. So first and foremost, and this is what the PG should actually be looking for when they are doing their 90Ds, that they should try to pick up these gray areas. Like these striations are what were described by, I think, in Lancet by Hoyt initially, like it was Lancet in 1972. And this loss of striations are the nerve fiber layer defect, which we should be able to pick up in the red-free filters. So red-free fundoscopy, if it is difficult, try to take a photograph, a red-free photograph, and try to analyze it later on. This is something that we should be doing it. Now, a red-free photograph actually enhances that lesion pretty well. So this is something that we need to be practicing. This part already the PGs are quite exposed to right from the first year itself. Even when I did my post-graduation in the first year, I had the opportunity of having RTQ, and we were like totally obsessed with the OCT for almost everything. So the heart of it is OCT, though adult retinal tomography and glaucoma diagnosis. Now fiber analyzer, they were also in play, but because of some issues like related to birefringence, related to the corneal reflectivity, and because HRT mainly gives regarding the optic disc imaging, OCT came out and it has stayed as the mainstay for RNFL analysis, including the other things that OCT provides. Yes. So I will just be talking about this slide regarding where you'd be looking for when you're analyzing the part of RNFL. So the mainly you need to center your position around the disc. Actually the machine does it for you. It's around 3.4 to roughly 3.5 millimeter diameter, around which it encircles the disc and makes the analysis regarding it, because the RNFL part is thickest around the disc. So the analysis is more prominent out here. And it comes with a color coding depending upon how much the standard deviation it falls outside the normal. So you get the red, green, or yellow, that is outside 1% or 5% or within the normal limits respectively. Now, this is one thing that came up, like if the interocular difference, not only in one eye, even if the difference between the two eyes is more than 9 microns, that is suggestive of glaucoma in any of the RNFL thickness analysis that you do. As I said, OCT became an obvious choice because not only the RNFL, it take care of almost the entire thing from the anterior segment to CCT to optic nerve. So it provides, especially in the COVID times, it provided a very good means of non-invasive, non-touch screening and progression methodology for glaucoma. Now, one thing that we do not do, we usually tend to interpret only the RNFL and the optic nerve when we are analyzing a glaucoma patient, is the macular glaucoma cell complex. This again comes as a part of it. Just you have to be focused that you need to do it. The central tube overlying the fovea, which comprises of the RNFL, the ganglion cell layer, and the in the plexiform layer. So these are the parts that are more prone to damage due to the IOP. So GCC actually estimates this only, and this macula has almost 40% of the ganglion cells. So any early damage will be picked up very nicely if you perform a macular GCC. Of course, the debate still remains whether to operate those pre-perimetric cases or not. So that we won't go into that, but yes, macular GCC is something which should be done along with the RNFL and optic nerve head analysis. And it is already incorporated in almost all the OCTs that we have, be it the Cirrus, be it the Spectralis, or even the source ones. Now, this is what we are talking about. Whenever you are taking a OCT, it has to be in tandem with your fundus finding and your perimetry. Just as in this case, if if you just go a retrograde fashion, if there's an inferior defect, perimetry superior defect is what you get to see, and GCC count is also being reduced. So all those things should be collaborated, and they should not be taken in silos. Okay, we have done this, and okay, we have proven glaucoma. You should be taking all these things into account to put forth a diagnosis. And basically, it becomes very important, as I said, in those confusing cases like myopia or a physiological cup where you have to differentiate. So when, as we already talked about it, disease progression, because the reproducibility rate in almost all the studies, especially with the spectral domain OCT, has been more than 96%. So it's an excellent tool for monitoring progression. And of course, perimetry, we do not deny that is a gold standard. But yes, OCT is something that provides you a very good reproducibility. And it is not like variability. As ma'am talked about, the same patient, you can get different results on different occasions. Okay, and depends upon also the reinforcement by the person performing the perimetry. But that is not the case with OCT. So pre-perimetric glaucoma, and as I said, the mimickers. Now, this is not a very clear image, sorry for that, but if you can see, the OCT actually did pick up an inferior defect, which slightly you can see even on the fundus, but it's a pre-perimetric thing. So this is where actually OCT comes in a big way. But yes, again, as I said, and in normal tensive glaucomas, but, whether to treat or not, that still remains a topic of debate. This is regarding the progression. As you can see in the fields, the slowly progressive one started with a disc hemorrhage, but slowly you get to see some field defect and a very good RNFL defect that is being depicted in the OCT itself. So disease progression is something with visual field analysis. Obviously, we have to go. That is where we treat. But yes, OCT can give us a lead into it and save the vision, obviously. And where to perform on that fundus, I already mentioned it has to be centered around, depending upon the machine that you use. But usually it is between 3.4 to roughly 3.5, you can say, a diameter centered around the optic disc. And there has been one study by Vasquez et al., which mentions it regarding the reference plane at which you should be analyzing. So the reference plane that has been demonstrated to be best is 150 microns above the retinal pigment epithelium layer. It comes with some limitations. Some studies have already mentioned, again, Vasquez has mentioned it, and some other studies which say that apart from the artifacts that you get to see, axial length, breast size, gender, and age, they all tend to affect the RNFL. With age, RNFL thickness decreases. In myopics, the RNFL thickness decreases. In hyperopes, it actually increases. So all these things have to be taken into account whenever you are analyzing the RNFL. And it's always good thing to compare with the other eye whenever in doubt and take the whole clinical picture. As I said, visual field, the optic nerve head, your perimetry, all should be taken together rather than siloed. And yes, RNFL topography, eventually when you are not able to pick up those things, a topographic image will help a lot. Like in this case, you get to see as I have been emphasizing, especially for the postgraduate, you have tried to pick these things. Even if the OCT is normal, you get to see these RNFL defects. And but since the OCT RNFL comes out to be normal, but on this topography, this slight depression. And yes, I forgot to mention one very important thing. Whenever you are analyzing this RNFL on OCT, there has to be very beautiful double hump pattern that you should be seeing. If there is any aberration to this double hump pattern, which actually corresponds to the ICNT rule, that indicates a glaucomatous change. And this is the slight defect that has been depicted on this map, but it doesn't come out that nicely on the RNFL analysis of OCT. So, yes. Now, again, apart from those other things, because the layer also contains vessels, it has also been propounded that depending upon the vasculature, also the OCT findings can vary. So these two things are the areas of interest in future, which can lead to like diagnosis of glaucoma and their pathophysiology as well. So just to, in the end, I would like to conclude that RNFL analysis is indispensable, because that is where the pathology lies, that is where the disease lies, that is where the anatomy lies. So it is helpful in screening, diagnosis, as well as progression of glaucoma. OCT remains the mainstay rather than the other things, but you have to rely on ophthalmoscopy and try to pick up those RNFL defects. And it helps in diagnosing not only the pre-perimetric, but also those mimicus. And it is quantitative, so you can actually follow it up very nicely and actually communicate to the patient also regarding the progression. And they should, as I already mentioned, they should be taken together as comprehensively. Thank you for that. If time permits and if the PGs are interested, I can just go for some examples, or I may just conclude. Thank you, ma'am.
Sir, you can give the example.
Thank you so much. So this is the take-home message.
Yes, ma'am.
So RNFL analysis is indispensable in glaucoma screening and progression and treatment. So
I think giving more examples will, make the things.
Yes,
Dr. Bharti, if you allow us.
yes,
Sure.
yes.
We'll just take 30 seconds. There are 5 or 6 slides regarding those examples where you tend to like this one. You just tend, this is a double hump you should be seeing normally, and this is the loss of the double hump pattern you get to see in a case of glaucoma. RNFL you can see in this side, it's grossly abnormal and it corroborates with the field. So this is something that you need to understand the field effects. When you just need to imagine where the field effect is occurring. So if it's a temporal field effect of that eye, the nasal arcuate defect is what is getting affected, and that should be reflected on this. Okay. And initially, when you perform perimetry, especially the postgraduates, when they perform perimetry, they tend, and if they do it, and usually most of the times, though we have those glasses, those rimless glasses, they tend to perform it with the spectacles on. That is something they do just to save time, to skip refraction or something. So, okay, aap chashma laga rahe, you put on your glasses, you will do your perimetry. So that leads to those all those rim artifacts, and that actually helps them to learn. Actually, if they get a rim artifact, explain to them why this happens. In the case of ptosis, if they just tend to forget to compensate for that ptosis and perform a perimetry, again you will get a defect which will not actually come on this visual field analysis of OCT. Now, again, this example, we can see a glaucomatous cupping. RNFL defect is not that clear, but this is the GCC part, which is abnormal, and you get to see these perimetric changes. Again, this is just for the examples. Sorry for that. This slide should have been more in for explanation purpose. So the arcuate defect superiorly and inferiorly, you get the RNFL defect on the OCT, on the examination, but on when you do a perimetry, it should correspond or corroborate with the location. Otherwise, it is either a non-glaucomatous thing or an artifact many a times.
Dr.
This is a
Abhishek,
correlation with HRT. Yes,
Dr. Abhishek, yeah, sorry to interrupt you. The previous field that you're showing, it is very, more like it's respecting the vertical midline, don't you think?
This one,
field?
ma'am.
Yeah,
This one.
like
Yeah.
almost like an evolving quadrantanopia.
Yeah, ma'am. This is almost, ma'am, but this is like a very early field defect that you get to see. And RNFL defect also you may see. Of course, you may call it a quadrantanopia.
Yeah,
But,
because it involves the center. That is why I was saying.
yeah,
It is
yeah,
coming
ma'am.
almost up to the
right,
center.
right, ma'am. But this is just a very early defect of only one quadrant. So yes, that can happen.
Yeah, on
Right.
grayscale, I think for the students, if this is there,
Yeah.
then at least
Yeah, they
some
have to
neuroimaging
definitely
should
they have
be
to
done
rule out.
before making diagnosis of.
Surely, ma'am. Yes,
Yeah.
ma'am. Yes, ma'am. I was just trying to emphasize regarding the field effect and what you get to see on RNFL, that they should be corroborating. But definitely, ma'am, you are surely right. They need to keep those neurological findings into mind as well. And yes, so that was the final slide. Again, as I said, GCC has to be an integral part of it. Not only RNFL on fundus photo red-free photography, RNFL, GCC, and perimetry. They have to be taken together. That and
Can I comment on this slide?
Sure, ma'am. That would be
Just
the previous slide, ma'am.
before this slide. Yeah,
This one, ma'am.
So as you were saying that central visual fields are also common in even glaucoma patients in 5 to 15% of the patients, and sometimes recognize in 24-2, and that is why nowadays we have 24-2C test, which delineates the central defects very early, and that is why it has been recommended that you can, I think you should also do central visual field evaluation in patients with early glaucoma. So these central visual fields are very commonly seen in patients who have this RNFL defect, as you can see in these black and white picture and colored fundus picture, that this RNFL defect is very close to macula. So when this happens, then you will get central visual field defect. And in a slide before that, also what you were saying as quadrantopia, yes, this one also, that quadrantopia.
This one, ma'am.
So here also, if you see in OCT, the RNFL defect is very close to macula. And that is why these visual field defects are coming up to the center, and they are very common in normal tension glaucoma patients. So I have seen several of them. You should, I think, try to rule out neurological cause. Can also be seen in glaucoma, especially in normal tension glaucoma, wherein you will see central visual field defects very early. And in OCT, when you try to correlate or corroborate the findings with the OCT findings, the RNFL defect is also very close to macula. So I think this is the correlation or corroboration you should do. So
thank you, ma'am. Thank you for pointing that out.
Defects and RNFL defects are close to macula in normal tension glaucoma, whereas in high tension glaucomas, they are not very close to macula. They are basically in the arcuate area and all.
Oh, thank you. Just
this is a very big tip she has given.
Yes.
The normal tensive glaucoma.
Yeah.
I'm like, well, just a question, ma'am. Like out. While I was just going through the literature, it was like when Quigley reported it, it was like there was a tussle whether the arcuate defects are more common, the slit like, or a diffuse defect. So there was a debate regarding that. Because for ophthalmology, like general ophthalmology, we usually definitely miss this thing whenever we are observing the fundus. So any comment on that, ma'am?
Arcuate defects are more common because in glaucoma, it is the damage to the arcuate bundles. So arcuate defects are more common, and the defect will typically start from the nasal area, as this picture also. So it will start from the nasal area as nasal step, and then it will progress to get involved the arcuate bundles. So there will be first the superior arcuate or the inferior arcuate, and then the other area also, and then biarcuate. And in normal tension glaucoma, as we have discussed, it will also involve the papillomacular bundle also. So I think, but arcuate, so most early defect is nasal step, and then arcuate fibers, biarcuate, and diffuse. I think it will eventually diffuse scotomas when the entire involved.
And one point for the PG sake, like whenever we are seeing a nasal, saying about nasal step. So it is like a nasal, on the nasal side of the field that we are
On the
saying.
nasal side of the
field
field.
side, right? So they
Yeah, and
always
it is
confuse it with the blind spot. Okay, this should be studying. So that is something I just wanted to mention it just for the sake of PGs. So like whenever you are like, ma'am, you can get a comment about on it.
yeah, blind spot is not involved, and that is how you can differentiate between myopia and glaucoma. Because in myopia, because of the peripapillary crescent, the blind spot, there will be enlargement of blind spot. And, the defect around the blind spot because of the extensive peripapillary degeneration. So blind spot represents optic disc. Okay, that area where there are no there are no axonal bundles. It's a cup. Okay, so like without any fibers, axonal fibers. So that is why there is a defect here that is called blind spot. And in peripapillary atrophy, there will be enlargement of blind spot. So if there is myopia and changes because of, then it will be mostly around the disc or the blind spot. But in glaucoma, it is mostly around the nasal step. And it will start from the nasal side.
Right.
Dr. Sunita, I have a very quick question.
Yeah.
For especially doing the biomicroscopy for the disc. What did you take for dilating the pupil? What we should look before doing that, and what precautions should we take? Because a lot of people are afraid to dilate the pupil in the cases of glaucoma. What did you take, ma'am?
So I think gonioscopy should be done before dilatation, because in India, almost 50-50 ratio is there of angle closure and open angle glaucomas. So if you have to first rule out angle closure glaucoma, if the angle is narrow, then you have, obviously, I think you have to be very, very cautious in dilating the patient. And even if you have dilated the patient, unknowingly, or somebody else has dilated, sometimes our patients are first seen by optometrists. If they dilate, then you have to give the patient either Dimox or some anti-glaucoma medication, because when nothing will happen immediately, but when the patient, when the pupil starts constricting, and when it is in the mid-dilated position, then angle closure attack can happen. So I think even if you have dilated it for whatever reason, then you can give the anti-glaucoma medications, Dimox plus one brimonidine combination, Dorzoxty or something, so that the pressure doesn't rise. So, but ideally one should do gonioscopy before dilatation. That is first I think you have to first see the applanation, then gonioscopy, and then angle is open, then you need to, you can dilate. But dilated evaluation is a must. At least once you should dilate and see the disc and RNFL clinically.
Thank you. Thank you, Dr. Sunita.
So,
thank you, Dr. Abhishek, for your nice presentation. So now I invite Dr. S.K. Mitra for a proper formal introduction of Dr. Sunita Dubey. I'm sharing slides from here.
Good morning once again. It's my privilege to introduce Dr. Sunita Dubey. She is the medical superintendent and head of glaucoma services of Dr. Star's Charity Hospital, New Delhi. She has done fellowship in glaucoma at Wills Eye Hospital, Philadelphia, 2002. She has got extensive experiences in training fellows in glaucoma for the past 2 decades. More than 100 publications and book chapters in various prestigious journals. She is a member of Glaucoma Task Force, Ministry of Health and Family Welfare, India. She is nominated as honorary professor by Indian Medical Association in August 2017. She is the treasurer of Glaucoma Society of India in the year 2012 to 14. She has received a Women Achiever Award in Healthcare from Business Ranker magazine. She is a member of AIOS NABH National Committee for Setting Ophthalmic Quality Standards in India. She is instrumental in setting quality assurance system at various ophthalmic institutes in India and Southeast Asia. Received several prestigious awards in AIOC, including E.T. Selvam Award, Best Paper Award in Ophthalmic Education, Epidemiology and Preventive of Blindness sections, and Best Oral Paper Award in International Congress of Glaucoma Surgeries. She is a reviewer of various prestigious peer-reviewed journals and voluntary faculty for Orbis International. with his extensive experiences in glaucoma services. I now welcome Dr. Sunita Dubey for her talks. She has got two topics to discuss: tube implants and periodic glaucoma. Dr. Sunita Dubey, please.
Thanks, Dr. Mitra, for the kind introduction, and Dr. Bharti Kashyap for having me here. So I'll be, can you just unshare this slide? I'll share my screen.
Mitra, please unshare the your slide.
Not share. It is from there.
So can you see my slides?
Yeah, now it is visible.
Yeah. Okay, so I'll be first.
Your full screen, please.
Yeah. Okay, can you see now?
Yes. Very much visible.
Okay, so I'll be talking first on tube implants. So tube implants we have been performing very, very frequently, and they are the primary choice for most of our secondary complex glaucomas, like neovascular glaucoma, post-PK, post-VR surgery, ICE syndrome, and FAK glaucomas. So these are the primary choice. And now with Asia Pacific, with Asian studies, the use is increasing even in primary glaucomas with good results of TVT and other studies. So we have valved as well as non-valved implants. So we have done AGV's valved implants extensively, and ADI also we have been doing for the last 3, 4, 5 years. And now we have an AGV or ACP clear path, which is the non-valved implant from Aman Glaucoma, a New World Medical. So before planning for the surgery, it is very, very important to meticulously perform the preoperative evaluation. And because the type and site of the implant will depend on the clinical diagnosis. And mostly we prefer the superior temporal quadrant because it is easy to perform the tube implant surgery and the low incidence of ocular motility disorders. However, some of these complex eyes have a lot of scarring. So you have to select the quadrant which has minimal scarring. So you can also choose superior nasal or inferior nasal quadrants. And also sometimes you have to use autologous or exogenous grafts. So proper placement of tube is very, very critical for good long-term outcomes. And I think this is the most crucial step because these patients may be having extensive peripheral anterior synechia and they may be aphakic or pseudophakic. So it's important to assess the extent of PAS and assess extent of and the position of the lens. Because if there are extensive PAS, then you can decide to put the tube in the sulcus, or if the patient is pseudophakic, also you can put the tube in the sulcus. But if the patient is phakic, then you have to put the tube mostly in anterior chamber. Also, management of primary pathology is very important because some of these patients may be having silicone oil in the anterior chamber or neovascular glaucoma, so NVI, or a lot of inflammation, or vitreous sometimes in patients with traumatic glaucomas. So you have to first take care of this primary pathology, otherwise the tube will get blocked by these substances. So I'll just show you the video of AGV implantation. So here you can give, I generally prefer to give corneal traction suture and then the conjunctival flap. Mostly I make fornix based, but it can be limbal based also. So you have to create the deep pocket deep into the fornix because you have to fix the plate of the tube at least 9 to 10 millimeter away from the limbus. So you have to dissect and make a pocket into the fornix very deep. Priming of the implant is very, very important. It opens up the valve and then just slide the plate inside the pocket which you have created. And then I use this nylon suture. You can use ethibond suture also. So here I'm using this mattress suture here. So it has to be taken twice and then just suture it. And similarly on the other side, and just rotate the this inside. Now just fix the tube onto the sclera, and it will minimize the movement of the tube in the post-operative period. So again, I'm using nylon suture here. So once you have fixed the tube, I generally put the tube at 12 o'clock. So it is 2 millimeter away from the direction of the tube, and 4 millimeter tunnel is made. So I cut the tube here, and then with the help of this 23 gauge needle, I introduce the bevel of the needle, which is around 3.2 millimeter. And once you have introduced, then you just change the direction and enter into the anterior chamber. Since it's a valved implant, you can put a little bit of visco or halon inside the anterior chamber so that immediately you can prevent hypotony. Now just measure the tube once more. It should be 2 to 2.5 millimeter inside the anterior chamber. So cut it and then just introduce the tube inside the anterior chamber. Here the patient, there was no PAS, so I have decided to put the tube in the anterior chamber. So this tube is nicely fixed now, as you can see, into the anterior chamber. And then you can apply one more suture onto the tube, and then the scleral patch graft. So I'm here using a corneal patch graft, very thin, like half thickness. And then finally you need to suture the conjunctiva. So this is the final picture. Now I'll just show you this AGV valve. I had shown you the valve. Now this is the non-valved implant. This is clear path. So now this is the recent introduction. Here again the conjunctival flap similarly. So you have to, it is always good to identify lateral rectus and superior rectus muscles, because you need to put the implant in between them. So this comes with the Prolene suture, as you can see here, because this is a non-valved implant. So here you have to tie the tube because you do not want hypotony in the immediate post-operative period. So you just tie it. And then once you tie it, just check the flow through the tube. So there was some flow happening. So I put another ligature over the tube and then tighten it so that there is no flow through the tube. So you do not want any flow in the immediate post-operative period. So once you have done it, the design, as you can see, is slightly different here. And then you just slide your plate in the pocket. And then, so this is 8 millimeter from the limbus. So once you have tied the plate onto the sclera, what you can do is that you just make a pocket here in the superior temporal quadrant and just place your suture in this quadrant, because later on you can remove this suture. And then the same way, 4 millimeter tunnel, 2 millimeter from here, because it is always good that your tube enters the anterior chamber at an angle. So once you have made this tunnel, you introduce the tube into the anterior chamber and fix your tube onto the sclera. So again, so this is the final picture. So here you can see the tube nicely into the anterior chamber and everything is okay. So the implant, again, the procedure is same, but here you have to put the wings of the implant under the rectus muscles. So you have to identify, the conjunctival flap is slightly bigger here. So identify the muscles. So this was the surgery which was done 3 years back. So here I am using the muscle hooks with this 40 silk suture, 60 silk suture. So you just loop it around the muscle, pull one end, and then just separate the muscle. So for the beginners, I think this is a good technique wherein you have just separated your muscles. Now I do not put these sutures. So once you have done this, you just slide your, this is the AGB, Adi implant. So you just slide it under the muscles, first one wing and then another wing. And then after fixing the tube, you just have to tie this as I had shown for ACP. So you have to put this suture around the tube to block it. So please remember that the valved implants need not be blocked because the valve takes care of the hypotony, whereas the non-valved implants, you have to tie the tube to prevent severe hypotony in the early post-operative period. And then you have to see by injecting fluid through the tube, and there should not be any fluid going into the tube. And once you are sure about it, then you can insert the tube without making tunnel also. So here I am just directly entering the anterior chamber, and then you can give this venting slits, which will facilitate the flow of aqueous early in the post-operative period. The rest of the procedure is same. You can also combine it with cataract surgery. So this was a patient post PK glaucoma, so with cataract also. So I performed phaco first, and after putting the lens, the tube was similarly placed in the superior-temporal quadrant. And here I am going to put the tube, as you can see, behind the iris because it's a post-PK glaucoma. So you do not want any corneal decompensation. So here the tube is being placed behind the iris in the sulcus. And the rest of the procedure is the same. So here you can see the tube in the post-operative period, which is behind the iris in the sulcus. And the patient is doing well. You can also do this with the K-Pro. So I have done a lot of patient like combined surgeries. So here this was a patient with corneal melt, acid burn, and the K-Pro was performed by corneal surgeon. And then after performing K-Pro, vitrectomy was done by the retina surgeon. So it's a combined effort. And after doing vitrectomy, the AGV plate was fixed beforehand only. And then you insert your tube from one of the ports, the superior temporal port, which was made earlier by the retina surgeon. So, and then you suture it and put a contact lens. So this is the post-operative picture. You should be able to see your tube to the pupillary area. So post-operatively, I think management is more or less same as you do for trabeculectomy. So you can get hypertensive phase in patients whom you have performed AGV implantation, and you can see this tense bleb here. And hypotony can also be common, especially after the non-valved implants. And it is more common in pediatric and myopic individuals. To prevent hypertensive phase, now what we can do is we give aqueous suppressants. As soon as the pressure goes beyond 12 millimeter in the post-operative period, you just start either iotim, timolol, or a combination of dorzolamide and timolol. So it can prevent hypertensive phase. And I have seen in most of the patients, now I start aqueous suppressants early, and you can prevent it. And you can also tap this bleb, very tense bleb, as you can see here. This is an encysted bleb, 1 month post-operative. And these high tension blebs, you can just perform tapping with 30 gauge needle on slit lamp, and it can sometimes remodel the bleb and can resolve the hypertensive phase. So complications, I will not go into the details, but the tube can get blocked in the early post-operative period by blood, fibrin, iris tissue, or lens material. So sometimes you just have to use very low energy YAG shots, and it will cause retraction of the blood, and it will clear of the blood, and you can, with extensive steroids and YAG shots, you can clear this blood from the tip of the tube. And this was one of the patients where the iris got incarcerated into the tube because the tube was very close to iris. So I just gave 1 or 2 shots with the YAG, and the tube, and the iris got relieved from the tube. And this was our patient, the case report which got published. And here we cut the vitreous with the end gripping forceps and anterior vitrectomy. And this was a case of traumatic glaucoma, wherein there was some zonular dialysis, and the tube sucked the vitreous from behind the lens. So this can also happen. And sometimes conservatively, you can give doxycycline and a lot of steroids and lubrication, and you can see this conjunctival defect, which is the conjunctival erosion, which gets healed. Sometimes you get 2 to 3% of the patients can get tube erosion, and tube erosion is common in high-risk eyes, and the eyes which has undergone multiple surgeries. So the tube erosion can also take place, and you can I'll just show you this video. This was a patient who was sent to us. This is a plate erosion. And what we did is that when we explored the wound, and when here I'm injecting Helon because there was hypotony because of this exposure of the plate and conjunctival leakage. So here traction suture, and then opened the conjunctiva. Then I realized that the tube was, by the previous surgeon, that the plate was sutured quite anteriorly. So I just removed it. I removed the adhesion, and it came out very easily. So then I just made a deep pocket, and since that tube was cut very short, I used a new AGV, and then the rest of the procedures were same. But then I realized that the conjunctiva is falling short because the patient had undergone multiple surgeries, 2 failed, trab, and then AGV. So I just gave this conjunctival relaxing incision, as you can see, and they are sometimes very helpful to bring the conjunctiva forward, to mobilize the conjunctiva. You don't have to give it deep, just give it in the conjunctiva, don't give it in the Tenon's capsule. So I had given a very large conjunctival incision here. Tenon's was still there. And by this manner, I could bring the conjunctiva, I could mobilize the conjunctiva, as you can see here. And then I used fibrin glue here to attach the conjunctiva onto this sclera. And then additional sutures are required just to ensure that it doesn't retract in the post-operative period. And after that, I used amniotic membrane. So amniotic membrane was stuck again with the fibrin glue. And finally, it was sutured. So this is the post-operative pictures. Again, I think you can get, I will not show everything because these patients, sometimes you get, they are sometimes referred from outside and you have to correct them. So this is again use of amniotic membrane and conjunctival advancement, and the patient was okay. And this is the last thing. To correct hypotony, you can use intraluminal tube stent. So here you are blocking the tube from inside with the proline suture. So you are just gripping the tube with microforceps and inserting this proline suture. So it will take care of hypotony. So to conclude, meticulous examination pre and post-operatively, frequent follow-ups, recognize signs of hypotony and hypertensive phase, and also look for development of complications. So if you perform meticulous surgery and frequent follow-ups and early recognition of complications, then your success rate improves tremendously. Thank you very much.
Thank you, Dr. Sunita. You have shown the surgery, but I've shown the management of hypotony post-op, and very nice presentation. So over to your next presentation, the management of pediatric glaucoma. Please, Dr. जिसको कहिए अपना वीडियो ऑन रखेंगे, सारे पीजी वीडियो ऑन रखिए.
Dr. Sunita, may I ask you a question?
Yeah, sure.
My observation is, while you are inserting the tube into the ball, either it's anterior chamber or in the sulcus. So when you hold the tube and you start putting it in, when you start shoving it in, there is always a kinking towards the junction of the main body and the tube. And many times it's very difficult. I think the most difficult part is making the tunnel and putting the tube inside. That is the most difficult part.
So earlier, actually, I used to do it, without making a tunnel, just 1 millimeter behind the limbus or 1.5 millimeter behind the limbus, depending on where to put the tube. So you can do it that way also, but over a period of time, I have realized make it snugly fit into the sclera, and then the chances of movement of the tube are very less. And it will prevent tube exposure. And there are several studies which suggest that even if you don't put scleral patch graft or corneal patch graft, if you just make a tunnel and introduce the tube to the tunnel, the chances of tube exposure are less. But yeah, it is difficult. You have to initially, practice how to make the tunnel and how to introduce the tube.
Ma'am, I had a question too. This is related to post-operative complication. There is a patient that we have operated for tube implant for traumatic glaucoma. He's an adult. He's having exotropia now, but since vision in that is really not bothered with exotropia, but he keeps having recurrent uveitis, low grade. Eye becomes red and it becomes painful. Otherwise, the tube is quite, the inside portion of the tube is quite well placed in the AC. There is no corneal endothelial touch, no iridocorneal touch, but still he keeps having flare and cells. So how to manage such patients, and is the tube in the AC cause of that, or
No, is it touching the iris?
No, it is not touching the iris.
Okay, and what was the primary diagnosis? Was it a case of uveitis before, or?
No, it was traumatic glaucoma, a firecracker injury in both eyes. Then he was operated for trap cataract in his childhood, failed trap, then again repeat trap, and then by adulthood he was a 0.9 cup with maximum medication. So he was referred outside, and he went and got an AGV implant done.
Maybe I think because of trauma, I think trauma can also lead to uveitis. So I think maybe because of trauma, it was not a case of primary glaucoma. It was
no. Glaucoma. But ma'am, the trauma history is more than 35 years old.
So recurrent uveitis
he's having after having the AGV implant done.
No, but how do you say it is having, like it is after the AGV?
Because we have been following him all through. I have personally been seeing him for 14 years.
No, but if the tube is not touching cornea or iris, and if the pressure is well controlled, then you can just treat the uveitis.
Okay. And pressure is also slowly mounting up. Like now with 2 medications, the pressures remain around 22.
Yeah.
I've made
So
it to 3
in
medication
AGB
now.
also, I think it is every year the success decreases. So there is attrition of 10% every year. So it is not every glaucoma and any glaucoma surgery, the results are not 100%. So over a period
Ma'am, in such
success
cases,
rate
if
decreases.
if peripheral anterior synechia is minimal and otherwise open angle glaucoma is there, then can MIGS be an option for him after this? Will it help a little more?
I don't know actually, but the success rate may not be that great because it's a long-standing glaucoma, 30 for 45 years. You can think of if the conjunctiva is mobile, you can do, if it is done in one quadrant, another quadrant trap can be done, or repeat tube can also be done.
Okay, ma'am. Thank you.
There's one more question. Ma'am, how do we avoid a very long or a very short tube? How do we gauge the correct size of the tube?
So you just
Preoperative.
place the tube on the cornea. If it is in the anterior chamber, then it should not exceed more than 2.5 millimeter in the anterior chamber. So you just place the tube onto
Right.
the cornea, measure it. You just from the limbus, just as I was showing with the caliper, you just measure the length of the tube. Should not be more than 2.5. So but to be on the safer side, because sometimes you need to change the direction of the tube. So what I do is just keep it long. And if it enters very easily, then cut it short later.
Okay.
Once you have
Ma'am, this
the position of the tube in the anterior chamber, then later on you can cut it. Because if it doesn't go from that side and you have to take it to another side, which is slightly longer length, then if you have cut it beforehand only, then you will be nowhere. Okay, so first cut it long, try to insert it, and then once you are sure that it will go from this side, then you measure the length 2 to 2.5 millimeter and then cut it and then insert it again.
Ma'am, what is your take on the tube extenders that are available? Like in the previous surgery, you showed that the tube was very short, so you used a new one, a new implant. Could the tube extenders that are available?
Yeah, they are available, but then the tube extenders have that very hefty, thing over it. So over a period of time, you can get conjunctival erosion from that side.
Right.
Okay,
Right.
but then some people are doing that, they are preserving the tube which has been cut, because the Adi tube is smaller in diameter.
Right.
Okay, so you just preserve it, etio it, and if you need, you can just insert it inside the tube and tie a suture.
Okay.
For approximation. So that can also be done. Like if you have some tubes which are cut before, you just preserve them and then etio them, and then you can use it. Tube extender can also be used.
Thank you so much, ma'am.
Should I move to another?
ये ट्यूब एक्सटेंडर क्यों लगाते हैं?
अगर ट्यूब छोटी हो जाती है, सपोज अगर ट्यूब रिट्रैक्ट हो गई, स्पेशली when the eye grows, so in children we leave the tube slightly longer. I'll show in my pediatric presentation.
So it does not touch the lens?
What? Tube?
Tube?
The tube is in the anterior chamber. It is just slightly into the anterior chamber between iris and cornea. So it doesn't.
So you showed na in post PK, in the PK patients, you put
in the sulcus, you put only when the patient is pseudophakic.
Pseudophakic, right?
You cannot put in the sulcus in phakic patients.
And what about your Capro patients? What is the follow-up? It is they are maintaining a good IOP.
See, Capro prognosis long term is not very good.
I know. That's what
because but for 3, 4, 5 years, it is just buying time and giving them some useful years.
Some functional vision.
Functional vision. So we cannot, we just try to succeed, but it depends, because infection is also very common in patients with Capro.
तो तुम्हारे केप्रो पेशेंट्स में फॉलोअप में कैसा रिजल्ट आ रहा है?
आजकल हम कंबाइन कम करते हैं, like first I do tube implant and then they do Capro, because combining any kind of keratoplasty or Capro with tube implant is not good, because tube implant will reduce the IOP. The sutures will get loose. So
First you do tube implant.
first tube implant and then later on K-Pro, or if there is no, because invariably in these patients, the IOP is going to be high.
So how many days after the implant you do K-Pro?
No, 1 month, 2 months, we can do.
One question regarding the bare welt implant, like the sizes are usually big, like sometimes you do not get the like 350 millimeter square, the larger ones. So is there like any effect on trimming the size on the efficacy of that device while implanting?
Yeah, people have done that also. If there's over filtration, then you can just trim and reduce the surface. And that is also being done. Although I have not done it myself, but it is mentioned in the literature. You can do it also.
Yeah,
You have
but,
shown the threading with the stitch. You show na showed the when it is
I had shown that you can block the lumen of the
block
tube.
the lumen. Yes.
Yes, you can do
we can
that.
trim the wings also.
Wings, you can trim
So
the wings
blocking
also.
the lumen is easier rather than
Yeah, so you can do
blocking
that.
is easier. Okay, over to the next talk, Dr. Sunita. Pediatric glaucoma management.
You can see the slides.
Yes, very much audible.
Yeah.
Can see.
So I think all are scared of the pediatric glaucomas because it's a blinding condition and can lead to corneal blindness or optic atrophy if not treated on time. So unlike glaucoma in adults, glaucoma in children, especially the primary glaucomas, they are very symptomatic. And these are the patients who you see in your OPD, and they have epiphora, photophobia, and blepharospasm. So you must have often observed that they just hide their face or they keep their chin down just to avoid the light. So basically they are because of the goniodysgenesis, and which affects the drainage of aqueous inside the eye. And so if you look at the normal angle development, there is posterior migration of iris and ciliary body from the Schwalbe's line at 5th month. So till 5th month, iris and ciliary body are attached to the Schwalbe's line, and then it starts separating. And in 5 months, you can see the scleral spur. So when a child is term, the scleral spur should be visible. And then after birth also, there is formation of recess. So after there's development of recess takes place only after the birth of the child. So what happens in congenital glaucoma is that there is goniodysgenesis. So there's arrest in the development of the angle recess. So there's no separation of the TM and the ciliary body from the Schwalbe's line. And as a result, there you will see there is wrap around insertion. As you can see here in this picture, the iris is inserted directly into the TM because there's no separation and there's no formation of the angle recess. And in more severe form, Schlemm's canal is also not very well developed. And that is why these goniotomies and trabeculotomies, wherein we are making a connection between anterior chamber and Schlemm's canal, are not effective, because in some of the most severe form of glaucomas, the Schlemm's canal is not permeable and it has not developed. So now coming to incidence, in the Western world, the incidence is 1 in 10,000 birth, but it is very, very common in Middle East population, 1 in 2,500. And in Andhra Pradesh, in India, it is 1 in 3,300 live births. So, and it is because of the high rate of consanguinity which is found in these populations. So there are various types of classifications which have been used in the past. So they can be classified according to the mechanism, primary congenital glaucoma, or associated with other developmental anomalies. So there are Hoskins, but now we are using this CGRS, which is widely used now, and this divides the glaucoma into various categories. So one is primary childhood glaucomas. So primary, that includes primary congenital glaucoma, and juvenile open angle glaucoma. So they come under the category of primary childhood glaucomas. So there can be neonatal glaucoma where the child is born with glaucoma. So these neonatal glaucomas, as I said, are more severe because there's gross dysgenesis of the angle and the other structures. The best prognosis is infantile, when the child develops glaucoma after 1 month and before 24 months. And then late onset or juvenile, wherein there is no enlargement of the cornea, because after 3 years, the cornea cannot enlarge, but then there will be other features which are suggestive of glaucoma. And then, so after primary childhood glaucoma, secondary childhood glaucoma, so it could be because of non-acquired ocular anomaly, non-acquired systemic anomaly, or acquired conditions like trauma, uveitis, steroids. And then they have made a separate category, glaucoma following cataract surgery. So these are the acquired, non-acquired ocular anomaly, as we see Peters, ectropion, congenital ectropion, uvea, Axenfeld-Rieger syndrome, PHPV, aniridia, microphthalmos. So these are some of the associated non-acquired ocular anomaly and non-acquired systemic anomaly. You must have seen patients who have these syndromes like Marfan's, Weil-Marchesani, homocystinuria, phacomatoses, congenital rubella, Sturge-Weber syndrome. So these are some of these syndromes which can also be associated with pediatric glaucomas. So I use this classification because this is related to defects in the developmental pattern, and it is very useful for the prognostication. Like if there is isolated trabecular dysgenesis, that means the other eye structures are normal. So here you just see this wraparound insertion or anterior insertion of the iris, as you can see here, or posterior insertion. So the prognosis of this isolated trabecular dysgenesis is very good. And here the patient will not be born with glaucoma. The glaucoma will develop after a few weeks or months, as I said, infantile glaucoma. But then there is other category, which is iridotrabecular dysgenesis. So here, along with trabecular dysgenesis, you will see defects in the iris or in the other parts of the eye. So this is, as you can see, Axenfeld-Rieger syndrome. And so here you, the child will be presenting with the other systemic features. As you can see, flat, broad nose, receding upper lip, prognathism, redundant umbilical skin. So these are some of the systemic features. So whenever you suspect a patient having Axenfeld-Rieger syndrome, then you have to look for the facial features and other systemic abnormality also. So you have to know the complete picture. And here, if you look at the gonio picture of these patients, you will see these broad-based PAS and bridging synechia. Then aniridia, also we see a lot of patients with aniridia who also have subluxated cataracts and keratopathy. So this is one of my patients who was born, who had congenital glaucoma also, but over a period of time, he developed this subluxation of the lens also, for which he underwent cataract surgery with aniridic IOL, and then later on I did Adi implant also for him. And you can see that over a period of time, the keratopathy increased so much. So it's a progressive disease, and aniridia is a progressive disease. So it's very important to take a detailed history, birth history, consanguinity. The history of consanguinity should be asked. Then if you do not think of any developmental cause, then you should also ask history about the acquired causes like uveitis, trauma, steroid use, or cataract surgery. And then also systemic associations, as we discussed. So first and foremost, I think it's important to examine the child under anesthesia. So examination under the anesthesia is the first step. And you should see everything right from the iris gonioscopy, pressure, and fundus evaluation under dilatation. So you should keep your EUS set handy while you're planning to do the examination under anesthesia. So these are the things which we keep ready. we have handheld slit lamp also, but you can perform the examination under microscope. Then you should have either eye care tonometer. I think the last meeting last Sunday, we discussed about all these tonometers, which is good and which is not so good in pediatric population. Then you should have, you should do axial length. Then you should even take the picture if possible, and UBM in patients who have Peters anomaly or anterior segment dysgenesis. So you will see these HAPS tria as the clinical findings, which are break in the Descemet's membrane, and the patient, they are present mostly in the peripheral cornea, then wrap around incision in the gonioscopic finding. And in older children, when the glaucoma develops after 3 to 4 years, you will not see any enlargement of the cornea, but there will be progressive axial myopia because eye anyway is enlarging. The sclera can enlarge, and then cupping will be progressing. And so all these examinations should be performed during your EUA or during your examination. Now, the question is whether you can use medical management for primary congenital glaucoma. So primary congenital glaucoma is a surgical disease. You cannot manage it with medication alone, but they are used as a temporary measure while the child is getting ready for the surgery. If he's unfit for some time, then you can use these medications. You can use beta blockers or topical carbonic anhydrase inhibitors. And mind you that brimonidine is absolutely contraindicated in children who are less than 20 kgs because of their disastrous central nervous system effects. So in newborn and in infants, I think it is absolutely contraindicated. One cannot give this eye drop. And surgical therapy is the most effective form. So how do you choose your surgery? So it depends on the age, severity of glaucoma, and associated structural defects. So in very mild cases, so as I said, best prognosis of isolated trabecular dysgenesis. And if a child presents like this with iridocorneo trabecular dysgenesis, then the prognosis, of course, is not so good for simple procedures like goniotomy and trabeculotomy. Then you have to resort to other procedures. So maintaining deep plane of anesthesia is very important in goniotomy procedures also. This was the child who had undergone first strapless trap because the cornea was hazy, but the pressure was still high. So I performed the goniectomy here. And you can see there's high iris insertion. And once you enter the trabecular meshwork and you start incising it, then you see this iris falling down and you see this white line. So this is the indication that your iris, which was inserted anteriorly, has fallen back, and you can now see the trabecular meshwork and the inner wall of Schlemm's canal. So you have incised the trabecular meshwork, you see this outer wall of Schlemm's canal, which is white. And here I had performed this bilateral surgery in a child with glaucoma. So again, you can see there is a very high iris insertion. So you use the Swan Jacob for goniotomy also, as we had shown last time. And high iris insertions, you're just engaging onto the trabecular meshwork over the iris. And once you start incising it, you see this iris is falling back. So that means you have severed the insertion of iris from the trabecular meshwork, and you see this outer wall of Schlemm's canal. So you see, do it around 120 to 140 degrees. So these procedures are very effective. These goniotomy procedures are very effective when the child presents with mild to moderate infantile glaucoma. As you can see, the success may be 90 to 95%. But in neonatal PCG, as I said, because when the child is born with glaucoma, there are other developmental defects also. So just taking care of the trabecular meshwork may not suffice. So the chances of success are very poor in one of these studies only 21% success of goniotomy in neonatal glaucoma. Then trabeculotomy you perform when you can't see the angle. And now in Western population, Western countries in US, now they're doing 360-degree trabeculotomy. So with the help of this micro illuminator or with the illuminated catheter, they perform 360-degree, and now you can perform even suture GAT as we had shown. I had shown in the last meeting. So 360-degree GAT can also be performed, and combined trap plus trap is the most commonly performed procedure in India, and Dr. Mandal has popularized it, and it works with both the mechanisms. You are doing trabeculotomy also with Harm's trabeculotome, and you are doing trabeculectomy also. So both the mechanisms are working here. So this was one of my patients with congenital glaucoma. So I tried to do goniotomy first, but it was not visible. So I did with the temporal incision, I tried to open up the angle a little bit, but I was not satisfied because the visibility was not so good. So as you can see, the limbus was so enlarged. So I did trap plus trap in this. So you make a flap as you make for trabeculectomy. The flap is slightly larger because limbus is enlarged here, and dissect the flap up to the clear cornea, up to the limbus, and then make a radial incision onto the Schlemm's canal. I just enlarge it on either side. And then with the help of this Harm's trabeculotome, you just insert it through the Schlemm's canal into the anterior chamber. So insert it up to 75% of the length, and then insert into the trabeculum, into the anterior chamber, and then close the insertion. So this was our paper, which was published in 2015. Again, I think the same procedure. So will not go. So the results are quite encouraging of trap plus trap in most of the children. And however, some children do fail, especially after goniotomy if the glaucoma is advanced. So more than 20% of these surgeries will eventually fail and require another surgery. So how to manage refractory congenital glaucoma, especially in patients who have other systemic associations or ocular associations like Peters, Sturge-Weber, and aniridia. So this is the algorithm. So you first perform angle surgery, then repeat angle surgery can also be performed. If it fails, you can perform trab or AGV or ADI or any non-valve implant. And then if it also fails, then you can have the option of performing second tube or TSC-PC, so cyclodestructive procedures. So there is no unanimity at all which procedure one should perform. In one study, 24% of the surgeons performed trabeculectomy after failed angle surgeries, 30% surgeons performed drainage devices, and 26% other devices. So trabeculectomy can be performed, but it is not very successful in less than 1 year of age. That is why we perform goniotomy or trabeculotomy in aphakic glaucoma, Sturge-Weber syndrome, or uveitis. Drainage devices can also be performed. So, but as a child's eye grow, the tube can retract, as you can see in this particular patient. So you have to keep the length of the tube slightly bigger. So I'll just show this case. So this patient presented to me when he was 4 months age. He had microcornea with partial aniridia and cataract, and left eye total aniridia. So trap plus trap was performed. So left eye developed RD in 2021, and then he underwent VR surgery with silicone oil injection with oil retention syndrome. It's not working. So the retina surgeon performed the oil retention suture with lensectomy and vitrectomy. The video is not working, and then AGV was performed. The child is doing reasonably okay, but the long-term prognosis of such cases may not be good, especially with the syndromes associated with congenital glaucoma. So you have to keep the patient under follow-up and see if any complications are developing over a period of time. There are several surgeries in the armamentarium of pediatric glaucoma also, to begin with goniotomy, then trabeculotomy, then trap plus trab, and then you can perform trabeculectomy or tube implant, or as a last resort, you can even do graded TACPC. So the main goal is early diagnosis and early surgical intervention to normalize IOP and prevent progression. But these children need long-term surveillance and follow-up, because the surgery may fail and you may have to do another surgery. And also most of these children have very high myopia, especially I've seen with the enlarged eyes, very high eggshell length, high myopia. And if it is unilateral, there are chances of amblyopia. So I think it's very important to correct the amblyopia as well. And need for assessment for the repeat surgery is a must. So I think once you have taken up management of pediatric glaucoma, it's a lifelong surveillance, which is important for these children. Thank you very much for your kind listening.
Very nice. I know that not for the a lot of concern for the PGs, because these are very advanced glaucoma surgical management. Still, for faculties, it is of importance, and the PGs also know what is this. So till now they were knowing only about trabeculectomy. So for the last 2 modules, they have learned minimal invasive glaucoma surgery क्या होते हैं, tube implant क्या होते हैं, pediatric glaucoma का इतना theory भी पढ़ाया आज. So any question?
Yeah, I have a very small question for Dr. Sunita.
Yeah.
Yeah. So many times when you decide that the patient has to be taken up for the cataract plus trabeculectomy in cases of glaucoma in kids. So basically, in such cases, in the case the sclera is very, very thin. So do you have any tips for that, for trabeculectomy in kids?
I think it's a very important question, because in children's eye, once the sclera is very thin because of the stretching of the sclera. And the other thing is that the amount of collagen tissue is also very less. So as the age advances, the sclera becomes thick in the sense that the collagen tissue is more as compared to water. So when you are making a flap in these children, it cuts like butter. I think that I had faced once because I just, started giving incision like you would do for adults. But as you cut with your blade, it just, it was cut through and through, and the choroid started showing up. So I think it's very important that you make the cut very gradually because its sclera is very thin and the collagen tissue is very less. It is very soft and it's like butter. So it's, I think that is the tip. So you have to be very, very gentle in handling the tissue of a child, because they are very fragile and very thin and stretched out.
Ma'am, in relation to this question, I just wanted to ask, what is the depth, how much depth you want to go? I mean, along with the ages, I think the depth will also differ regarding the thinness of the sclera.
So here in congenital glaucoma, because you want to identify the Schlemm's canal. So it is 2/3 thickness of the sclera. So you just make gradual, entry and just assess the sclera, the thickness of the sclera. And it should be like 1/2 to 2/3, but in children, I prefer 2/3. The identification of the Schlemm's canal becomes very easy if it is 2/3.
Thank you.
Ma'am, as a beginner, I want to share my experience for congenital glaucoma. In the first few cases, the first problem that I used to face was the eye is so big that the superior part of the globe exposure is in itself difficult. Sometimes the cornea is so thin, if you put corneal traction suture, that itself either cuts through or sometimes it becomes too deep. So that is the first problem that you face. The second problem is identifying, because the anatomy is all distorted, so the blue zone that we normally think is very wide, and you think you cannot, it's not so easy to identify where exactly the Schlemm's canal will be. So initially I had started by doing just very like fine scratch incisions over the possible area where the Schlemm's canal should be, and by doing scratch incision, very gradually you are going deeper, and then at one point you start seeing fluid coming out, and then probably you enlarge it with a proline. You try to thread proline through the Schlemm's gland, and if it starts passing and you see that it's not going into the AC or it is not getting displaced, so that probably identifies the Schlemm canal quite easily.
Yeah, so at the junction of blue and white, as I say, I think, and you can sometimes see that scleral spur as the white band. And in most of the cases you can see, so you just start making a scratch incision, as you're saying, over the scleral spur, and then enlarge it on either side. So as you rightly said that it should be superficial, and then as you go deeper, you also increase the length of the incision, and sometimes you can just hello, yeah. So you can just see that ooze of aqueous out of Schlemm's canal. So that is the, and sometimes they also see, if you just press on the jugular vein here, you can see blood in the Schlemm's canal also.
Dr. Sonali, can you stop here, please?
Are we done with the time or something?
There is a screen share which is happening and it is showing Zoom. Hello.
So I don't know, sir, why it's happening. Some problem in my laptop, I think. I don't know. I'm just getting occupied there.
Anyway,
Dr. Savli, try stop sharing screen. Stop sharing.
Actually, I don't know how to do that. I don't know, something happening.
You want to present, Dr. Sonali?
No, sir, something is happening. I don't know. My laptop is hanging.
Don't do screen share.
Just take care of that, sir. That's okay, sir? No, it's okay, no?
I don't know. The Zoom doesn't want to see my face. It's not like my video.
I don't know, sir. I'm not doing anything now. I don't know why it's happening.
It's okay now. I think it's okay now.
Should I invite Dr. Utpala for the thank you?
Yeah. Please.
Okay.
We had a very interactive session.
Dr. Utpala.
Dr. Utpala, you're looking beautiful. You're looking beautiful.
Always tell that. Thank you. जो भी है, at this stage and age of life, सारा ले लेंगे. A very good morning, all of you. Myself, Dr. Utpala, on behalf of Jharkhand Ophthalmological Society, would like to extend a heartfelt vote of thanks to each and every one of you for being a part of this event. I would like to start by thanking Dr. Bharti Kashyap and team who have worked tirelessly to ensure that every aspect of this event runs smoothly. To our keynote speakers, Dr. Anindya Anuradha, Dr. Abhishek Onkar, and especially our guest speaker, Dr. Sunita Dubey, thank you for sharing your insights and expertise with us. Your presentations have been both informative and inspiring, and Dr. Sunita, we are honored to have you with us. I would also like to thank our sponsors, Entod Pharmaceuticals. Lastly, I would again like to thank each and every one of you for attending the event. Your presence here today has made it a memorable and meaningful experience for all of us. Thank you.
Thank you. Thank you very much.
Thank you.
I think Dr. Bharti.
Dr. Mitra, can we call a close to this meeting and leave now?
Yes, yes. Dr. Bharti is not here, so I declare this meeting ends. And thank you very much once again to all of you for this Sunday morning engagement. Thank you very much. Thanks.
Sir.
Yes.
Yeah, Dr. Bharti, please say bye to everyone.
Bye.
Bye.
Bye, everyone. And it was a very fruitful meeting. And this time the CCL people and the Kachchi Memorial people really kept the camera on. And the PGs should always keep the camera on. And I truly appreciate the CCL.
Talks are very engaging actually. Talks are very engaging.
Yes, very nice.
Very nice.
And next we will meet on 19th of January for the cornea model. 19th February. We will update everyone in the PG official group.
Thank you.
Amir, Sana, अच्छा लगा?
Yes, ma'am.
Yes, ma'am.
सब लोग हैं ना वहाँ पर?
Yes, ma'am.
Yes, ma'am.
अब डाला गया?
Yes, ma'am.
ठीक है. And हम लोग इसका लिंक भी शेयर करेंगे. So thank you to so can you hear the INTOT people? Thank you so much for the support you gave us.
Ma'am, can we conclude?
Yes.
Okay, ma'am.
So please share the link also so that we can share in our JHOS group. Thank you so much. Bye.